Hello, good morning.
Morning.
Good morning.
How are you? Just share my screen. Okay. Let's see here. Missing Uzo. And is Sergey on vacation?
Yes, Sergey's on vacation. Uzu might be a few minutes late. She just texted on the group.
Okay, we'll get going. All right. Why don't we start here with Grace. So Grace, this is a Zeo patch recorded on a patient who has a pacemaker. And my question to you is, what's happening in the second panel? What kind of pacemaker does this patient have, do you believe, in terms of pacing modality? And what do you think is happening in the second panel?
So what jumps out to me is the P waves that look like that are not conducted, but I'm just going to look through the other ones. So in the number 2 box, initially it looks like we're being V-paced because I don't see a noticeable P wave before each of the QRS. And then it looks like some kind of an atrial rhythm starts to kick in, but the PR interval is not regular when it starts conducting. So,
well, what kind of pacemaker do you think this is? Is this a single chamber? So I agree there's ventricular pacing. So is this a dual chamber pacemaker or a single chamber pacemaker, do you think?
I think it could be a single chamber with just a ventricular lead.
Why?
Okay. When the atrial rhythm starts coming in, I'm wondering if it's picking up, sensing it abnormally as a ventricular rhythm that it wouldn't have if there was an atrial lead. Is that possible?
No, I'm not sure I understand that explanation. It doesn't seem to be DDD pacing in the least. So if we had dual chamber, then we would have made it that setting. So if we look in panel 1, I think you would agree that there is no relationship that can be discerned between the atrial depolarizations and the ventricular. Do you agree with that?
Yes.
P wave, look at this PR, this PR, this PR. There's a P wave probably somewhere buried in this T wave. Excuse me. Some P waves over here. So this is just plain ventricular pacing, so-called VVI pacing, right? First letter stands for the chamber that's paced. The second letter stands for the chamber that is sensed. And then the third letter is suggesting that it will be inhibited by ventricular activity. And the other reason you know that it's not dual chamber is that the R-to-R interval is very fixed, right? In all the panels, the R-R interval is very fixed. But why is it? So we're pacing along. It looks like we're pacing at a rate of about 60 or 70 beats per 60 beats per minute. And then all of a sudden, there's these P waves and there's no obvious pacing, right? So why is it that this patient, why do you think this patient, what could explain why this patient stopped pacing? This clearly is not, if I told you the patient was programmed to VVI at 60, I think you would agree that this is not a rate of 60 from this to this QRS. This is in fact like a 2-second pause, or nearly 2 seconds. So how would you, a second and a half, how would you explain this? Is this a pacemaker malfunction? It says here possible pacemaker malfunction. Do you agree with this electronic assessment?
Yes, I would say. Yeah, I can't think of a reason why I would do it on purpose.
Right? It's probably unlikely that I programmed it that every day at 7:41:01 it should do that. So why do you think this might happen?
I was wondering if it was inappropriately sensing something. But it's unlikely that an atrial rhythm would be sensed as a ventricular rhythm, right, Dr. Fast? It's the
Correct.
voltages.
Unless the lead happened to be sitting on the AV valve ring and you somehow could detect A and V, right? Like, you know that when we put a coronary sinus catheter in the heart, we can record both atrial and ventricular depolarizations on that lead, right? But
Mhm.
that's unusual. We wouldn't put a permanent pacemaking lead there usually, except in circumstances, and we certainly wouldn't epicardially place it that way. So you're right. This is an example of ventricular oversensing. So it's sensing something in the ventricular lead, because remember that the way that the pacemaker works is that it will always try to maintain whatever the lower rate limit is of the pacemaker. And so this is obviously a rate that is much slower than 60 beats per minute. And so the reason it is not pacing is because it thinks the rate is at least 60 beats per minute. Therefore, it must be seeing some kind of activity on the ventricular lead, which is inhibiting the device from pacing. And in fact, when we interrogated this device, we noticed that there were episodes of intermittent noise, electrical noise on the ventricular lead, which is likely due to an insulation problem in the lead that was causing this to happen with some regularity. I think it happened like 50 times in the 24 hours that the child wore this device. And so, okay, so now you know the device is oversensing something. So how would you adjust the pacemaker, or how could you fix this? What would be your troubleshooting approach?
I could increase the number for the sensitivity, so decrease the actual sensitivity of the lead.
That's right. You could make the lead less sensitive. So let's say you're in the office and the artifact you record some intracardiac electrograms, which you can do in a permanent pacemaker, and you see it happen right in front of your eyes. And the electrogram is, say, 5.6 millivolts. So you could make the sensitivity, say, 8 millivolts, so that it ignores signals that are lower or smaller than 8 millivolts. Actually, we did that. That's what we did when we saw this phenomenon. And we repeated the ZO and continued to see this. So any other thoughts on what you could do?
I'm not sure, Dr. Paz.
Well, you're sort of limited. You could make it less sensitive, but remember, there is one risk of continuing to make it more and more insensitive. Yes, you will potentially avoid oversensing stuff on the ventricular lead that you ought not to be oversensing, but you also could undersense a PVC, and you could potentially put a paced complex on a T wave and cause life-threatening ventricular arrhythmia. So you really do need pacemakers to be able to sense as well as pace. Now, this particular patient had a very, very slow underlying ventricular escape rhythm. So you might have gotten away with it. In other words, you could have essentially made it almost equivalent to a VOO pacemaker, where it's pacing and it's not sensing at all. But that would potentially invoke the risk that if the patient ever were to have a PVC or spontaneous rhythm at any time, that it would be undersensed and it could be dangerous. So we would not generally leave somebody VOO except for a very limited period of time when they were being monitored or observed, such as perhaps during surgery or something. occasionally, if you're going to use a lot of electrocautery in the surgery, might temporarily program somebody VOO as long as there's an anesthesiologist monitoring the rhythm, ready to defibrillate in the event of an untoward event. Because things like electrocautery can cause enough artifact that it will cause inhibition of a pacemaker. Sometimes we'll do that, for example, if someone's having a very big operation like scoliosis surgery. But you would never leave somebody unmonitored in a VOO mode. And so basically, it happens in this patient that they had 2 ventricular leads. And so we were able to program the device to use the alternate lead. In this particular case, a dual chamber pacemaker was implanted and the 2 ventricular leads were plugged into the atrial and ventricular ports of a pacemaker, a dual chamber pacemaker, because there were concerns that the leads were not great. And so the patient had the pacemaker reprogrammed to pace through the other lead, and that was determined to be safe and to work properly. So presumably something happened to this lead, such as a insulation break or something. So this is an example of over-sensing and how we would address it. Okay, move on. Okay, let's see here who we got on who we have on the call here. Let's go to your colleague in crime, Dr. Bonsall. What is the rhythm of this patient, and what type of pacemaker in terms of what is the program, would you say, this patient?
Good morning, Dr. Bass. So I am looking at lead 2 right now. I do see a P wave, but the PR interval is long in the second beat, and then the next beat, it looks like the P wave is superimposed on the T wave, and it does not. And then there is a ventricular pacing artifact. So I would say it is VVI paced.
That's
because I don't see any relationship between P and QRSs.
That's right. So this is a patient with a single chamber pacemaker. Let me ask you a question. Let's say you have a transposition VSD patient who develops a complete heart block following surgery. Which kind of pacemaker would you ask the surgeon to place? A dual chamber or a single chamber pacemaker, and why?
I mean, if it's a newborn, I don't think we'll be able to accommodate a dual chamber pacemaker.
Why do you say that?
Because of the size of the baby, it's difficult to position leads in.
You've never seen a baby with a dual chamber pacemaker?
No, actually I have. Yes, we have babies right now who have dual chamber pacemaker. In that case, I would ask for a dual chamber.
So we can put a dual chamber pacemaker in small patients, right? We have epicardial leads, and we now have bipolar epicardial leads, the so-called steroid-eluting Medtronic leads, which are terrific, have been around for roughly 20 years and work very, very well. But it's a little bit of a big deal, right? You have to do a sternotomy, and you have to, it's harder to place an atrial lead than a ventricular lead. How is this decision made? Why would we put a single chamber or a dual chamber? So let's start again with the example I gave. A patient who has an arterial switch operation, has good ventricular function, otherwise excellent repair, but is in complete heart block. Does this patient need a dual chamber pacemaker? Is a single chamber enough? How would you make this decision? Hello?
If I'm just thinking.
Okay.
I mean, if we expect it to resolve in like if we expect it to resolve by post-op day 7 or 10, then we will just have temporary pacing wires. But I assume now you're talking about that this is like complete hard block, like it's not post-operative.
We would not put permanent leads generally before post-op day 8 or 9.
Yeah.
Studies have shown that up until that day, there's a reasonable chance of recovery, but after about day 8 or 9, the chance of recovery is below 5%. So that's the time we would normally put a permanent pacemaker. So let's assume again, we have this transpo who is now post-op day 10, has not recovered conduction. So Dr. Murphy, our surgeon, will say, has been asked to put the pacemaker in, and he asks you the question, single or dual chamber?
I'm not sure. How would I make that?
So what are the advantages of dual chamber?
So you will have, you can have AV synchrony.
Right. And what does AV synchrony confer to the patient? What does that do for you?
It
Why-
better cardiac output.
Mm-hmm. How much better? So the answer is it really depends on how good your heart function is.
Okay.
Somebody who has very poor cardiac output, a dual chamber pacemaker is very important. Having AV synchrony is very important. It could increase cardiac output by as much as 20 or 25%. However, if you have completely normal ventricular function, it may only be as much as a 5% improvement in cardiac output. Okay. And so in terms of cardiac output issues, you probably don't need a dual chamber pacemaker in someone who has normal heart function. What would be another reason you would consider putting in a dual chamber pacemaker and getting AV synchrony? What other feature of cardiac performance could be enhanced by having a dual chamber pacemaker versus a VVI, asynchronous VVI pacemaker?
Better longevity, because if it's sensing, like if it is sensing and then pacing would be better than it's always just pacing.
I see. Except that sensing does, if you have a single chamber pacemaker, it doesn't have to sense the atrium at all.
Mm-hmm.
So, and you would be pacing the ventricle 100% in either approach, right?
Mm-hmm.
So should be roughly the same in terms of battery length. What about valve regurgitation?
Oh yes, so the valve regurgitation would be lesser with ascens V pacing, like dual chamber.
Right.
Because again, there would be AV synchrony.
Right. So AV synchrony is very important in somebody who has AV valve regurgitation. And then the third reason that it might be useful is in a patient who has a single ventricle, because we know that in general, mortality and survival is worse in single chamber in VVI paced single ventricle patients. In the 1980s and 90s, the group in Texas, led by Richard Friedman, were very big advocates of ablating the AV node in people who had, in Fontan patients who had atrial flutter. Their belief at the time was that atrial flutter ablations were a waste of time, that they didn't work well, that it was hours and hours of effort for very little benefit. And so they actually undertook an approach where they ablated the AV node and put VVI pacemaker in. Turns out that that was not a good idea, that patients in general died more. Mortality was much higher, survival much worse in people who are asynchronously V-paced in single ventricles. And so generally speaking, because by definition, a single ventricle is at lower output than a two ventricle patient, we would almost always try to get AV synchrony, whether that would be A pacing in somebody who's in a slow junctional rhythm or AV pacing in someone who is in complete heart block in a single ventricle patient. I'm sure you're all aware we have a patient upstairs today who has complete heart block and is a single ventricle and has a dual chamber pacemaker, which is working very well. that is the reason that patient has a dual chamber pacemaker, because AV synchrony is important in maintaining good cardiac output in somebody who only has a single ventricle. But I think the point I'm trying to make today is that although we have the technology to do a dual chamber pacemaker in all patients, in the old days, a patient like the one I'm describing, a transposition VSD with heart block, we would very routinely put a VVI pacemaker, and patients did very well like that as young children, because good function patients with two ventricles don't generally need AV synchrony. Yes, it would be better with AV synchrony, but there's also a price to be paid. A single ventricular pacing lead can be placed through a subxiphoid incision or through a small lateral thoracotomy, whereas a dual chamber pacemaker epicardially has to be placed through a sternotomy, midline sternotomy. So it's a much bigger operation. Also, I'm sure you're aware that there are new data that have come out from the group in Boston and others that at late follow-up, there are rare patients who have strangulation of their epicardial coronary arteries from old pacing leads that are epicardial. So it's not usually from where the lead was sewn on, it's from where the slack is overhanging the ventricle. And there are rare cases of patients who have either died suddenly or who have had surgeries where it's been demonstrated that there's a substantial narrowing of a coronary because of compression from scarification of the slack of a lead. And so the point is, the less littering we do in the chest with pacing leads, probably the better. And so, my general approach is that if I have a patient who has two ventricles, does not have a lot of AV valve regurgitation, has good heart function, if the surgeon would prefer to put in a single chamber pacemaker, it would usually be my preference to put in a single chamber pacemaker, because patients do extremely well like that in general. There are rare patients who develop dysfunction, but it's unusual. So just thought I would go over that little point today. Okay, let's move on to the next one. So this is a 16-year-old boy who has come into the office with palpitations. And why don't we go to Neha Luwalia. So Neha, this is the ECG. Patient is in some kind of tachycardia.
Right.
And, I'm just going to show you what happened. This happened in the office. So the patient, this is 3 simultaneous leads,
Mm-hmm.
VVF and V5.
Mm.
So
Mm.
what do you think is going on here? I should tell you the patient, I believe, is a teenager.
Okay. So in tachycardia, the heart rate's around 150. And then there is, it just breaks suddenly and goes into sinus, where you can see the PQRS very nicely. And the QRS complexes in the sinus beats, as well as the tachycardia beats, could say are quite similar. So I would think, and it doesn't look like PR is that short, and don't think those are delta waves because the PR looks okay. So I would say some sort of ORT could be AVNRT based on his age. He's 16 years.
So is there anything about I agree, those are the two most likely diagnoses, ORT or AVNRT. Is there anything about this tachycardia, the tracing, the heart rate, that would make you lean one direction or the other? I believe I have here I think this is the 12 lead that was obtained after. I don't know if that matters to you. I'll show you the termination. It's probably more important.
So the thing is, if we can see retrograde P waves which I'm trying to find. If we tend to see the retrograde P waves, then that's more likely an ORT from an accessory pathway versus if we don't, then it's AVNRT.
That's correct. What RP interval would be most consistent with an accessory pathway?
80, 70, and above.
Greater than 70 milliseconds.
70, yeah.
So that's exactly right. You see the retrograde P waves, almost by definition, they are following the QRS. And so if you see retrograde P waves, usually that means it's ORT. What about the heart rate? Does that give you, does that help at all?
Yes. ORT, actually at this stage, I don't know. It could be quite similar though. AVNRTs can be less faster. ORTs will be faster.
Less faster is sometimes referred to as slower.
Slower, yes.
So
Pardon my English. Yes.
in general, AVNRT is usually slower on
Slower.
but it isn't 100% true. But I think the point is that if you look at these QRSs on the right, where we're clearly in sinus rhythm, and
Mhm.
left, they look very similar.
Similar, right?
And when we look in the T waves, we don't really see an obvious retrograde P wave.
Yes. Mhm.
Similarly, the rate is slow. It's pretty slow tachycardia rate for a child, right? 150 beats per minute.
50. Uh-huh.
So I don't know what this patient has. I think we're going to be doing an EP study on them at some point, but I think it is, if I were going to guess at this stage of the game, I would guess that this is AV nodal reentrant tachycardia. But this was lucky it happened in a doctor's office, but we'll have to see. We don't know yet. So, okay. And now this is the EKG, and I just wanted to show one thing about this. So sometimes when we look at an EKG like this, and you look at this lead, some of these leads here with this very wavy baseline, you might have the impression that the patient is in some kind of maybe atrial fibrillation. But always look at the other leads, because these are all simultaneous. And I think you would agree that in some of the other leads, it's very obvious that this is sinus rhythm. So this is just some kind of artifact here and so this is sinus arrhythmia with some artifact on the AVF lead. Okay. All right, good job. All right, so this is a patient who has, who by report, it says in the records that this is a 19-year-old with sinus node dysfunction. They have, well, look at this is a download from a pacemaker remote monitor. So this is the electrogram from the atrial lead, and this is the electrogram from a ventricular lead. And it says that the patient is programmed AAI at 60 beats per minute. And I guess my question, and this is the patient's pacemaker program. And we see here that the atrial lead impedance is 342, the ventricular 855. Those are within normal range. The output on the atrial patient is programmed AAI at 60, and it's programmed with 6 volts and 1.5 milliseconds. So this is a very high output. So whoever programmed this device presumably believed that the threshold was very high on this lead. And this is programmed with no output because it's only programmed to AAI. So I guess my question is, what do you think is going on here? So I'm going to ask David Barris, what do you think is going on here?
So I'm seeing that it seems like you're saying the top one is the atrial rate, and that seems to be quite a bit faster than the ventricular rate.
Yeah.
So the atrial rate is looks to be even faster than 150. It's almost like 160 beats per minute. And the ventricular rate has about, let me see how many. boxes we're dealing with here. So we have
A rate of about 70 or so.
so 70. So I'm wondering if we're having almost like a 2-to-1 block of our AAI pacing. Well, it's programmed at AAI at 60. So I suppose that we would want to inhibit if we're
Right. So we're not pacing, and actually you can see down here what the device is doing, right? It's asensing. Then there's an A that's falling in the refractory period, so they call it an AR, but it is sensing it. Asense, AR. And so the cycle length of the atrium is about 320 milliseconds. So the atrial rate's like 180, 185. And the ventricular cycle length is about 630, right? These are these. So their rates a little faster. So you're right. There's two possibilities here. Either the patient is in some kind of atrial reentrant tachycardia with, as you said, what looks like probably 2-to-1 conduction, or this could just be sinus tachycardia, and the AV node doesn't work very well. Now, somebody put a dual chamber pacemaker in this patient, so presumably there was some concern about AV conduction in this patient. And I think you could make the argument that if this is sinus tachycardia, which it certainly could be in a 19-year-old, heart rate of 170, 180, then this patient's probably not programmed properly, right? Because they can't conduct at 170. Now, if
Right.
they were a Fontan patient, and it would be unusual to have a heart rate this fast in the atrium. So we would presume that this is atrial flutter of some sort, or intraatrial reentrant tachycardia. But the fact that the patient can't conduct at this rate is concerning, and it suggests that this patient probably should be programmed in some kind of a dual chamber modality. Now, it may be that at slower rates below this rate, he does conduct 1-to-1, or she does conduct 1-to-1. But at this fast of an atrial rate, clearly there is not 1-to-1 AV conduction. So I think it's an example of a patient who who's probably not programmed optimally. Now, I don't know why the patient is programmed this way. This is not my patient, but it's an interesting question. And if this is sinus rhythm, then I think we would agree that this is not an example of a patient who has sinus node dysfunction. So and it turns out this was the sinus. It's hard to know what this is. It does look at the end as if whatever's going on here sort of abruptly ends, right? You notice there's like a pause. So I do wonder if this was an atrial arrhythmia that broke, and then, because there are no A's here. Looks like there's a PVC, and then it breaks, and maybe this is sinus. So I don't know. We don't have the rest of the strip, but it's interesting. It does look, though, from this 270 here, like probably the next day is fast. So this is probably some kind of sinus tachycardia. So interesting. Interesting tracing. And this will be our final one today. This is a 16-year-old who was complaining of palpitations, and this was recorded on a 24-hour Zio. And I'm going to ask Dr. Uzoma Obiaka of Alabama what she thinks is going on here.
Good morning, Dr. Paz.
Good morning, Uzo.
So looking at the tracing study from the upper strip, we see that there are P waves that are being conducted in the first 4 beats. The PR interval looks to be consistent and looks to be normal. So we go, and then when we have the 5th beats, we lose. We're not conducting the 5th beat. There's a dropped beat. And then we go back into the conducted beats. And I think for the rest of the beats, all the P waves are conducted still with a regular PR interval. The heart rate does lengthen in the lower strip. we go from a heart rate of about maybe 60 to something much longer. So let me just make sure I'm not missing any other dropped P's. And I am not. I don't think I'm missing any other bits.
So what kind of, do you agree with this computer's assessment that this is second degree AV block?
Yeah, I mean, it looks like a wanky back. But it's just, yeah, one bit. So yeah.
Right. So is this a concerning finding? Note that this is recorded at 2:17 a.m.
No, it's not concerning. People can wanky back while sleeping.
Right. So the question is, do you see any PR prolongation before this? One could argue that it's extremely subtle. I do think that this PR interval is ever so slightly longer than this PR interval, but we would need to take calipers out to know. Generally speaking, even if I can't see prolongation in the PR interval, if I see only one non-conducted P wave, I'm usually willing to assume that this is a Wenke Bach or Mobitz type 1 versus Mobitz type 2. Where is the block in 1 versus 2, Uzo?
1 is above the AV node, and then 2 is below the AV node.
Almost.
Infrahisian,
Right.
suprahisian, and infrahisian, sorry.
Right. Suprahisian, meaning it's at the level of the AV node, whereas Mobitz 2 is infrahisian, which is His Purkinje disease. So with one single P wave dropped at 2 in the morning, we would generally not get too bent out of shape over this observation. So I usually will consider this to be Mobitz 1, which is not as worrisome. It could be Mobitz 2, but a single non-conductive P wave usually ought not to get us too bent out of shape, especially at 2 in the morning. Were this recorded during the day, maybe on a rhythm strip while a patient was getting their EKG, this would be a little bit more concerning. But in a sleeping patient who's healthy, may have normal high vagal tone, 16-year-old, this would not be an abnormal finding. So good job. Okay, I think with that, we're going to stop a little early today. Thank you very much, everybody. I hope everybody has a wonderful day. I'll see you in Sinai in just a little while.